Thank you everyone for your patience and for coming today. This is a clinical education session as part of our series with virtual specialist consults, where a topic I think close to a lot of our hearts, but also to patients that we work with around pediatric sleep problems and the way that we can best support families and kids in this area. Next slide, please, Aveena. Oh, very nice of them to put this in. I had more hair then. My name's Morgan. I'm a GP. I do a bit of medical education as well. And my job is with VSC is to help try and integrate across the state of Victoria. And very briefly on that note, you'll notice there's the patient. There are some new item numbers that have come on with the MBS called patient and support numbers, which you can use if you're joining a consult with another specialist. And it gives the patient, or the rebate is a bit higher. I can send through the information about it. It only came out earlier this month, but it's a really good step in the right direction. Next slide, please. And I'm not sure where everyone's joining us from today, but where I am, and I'd like to talk on behalf of VSC as well, that we acknowledge the traditional custodians of the land on which our health service is built. Those are the Taunurung and the Wurundjeri people, and we acknowledge their continuing connection to land, waters and community, and pay our respects to the people, the cultures and the elders past and present. Next slide, please. Very brief housekeeping. Audiences listen only. Please use the chat if you have any specific questions, and then we'll go through it at the end of the presentation. For the Continuous Professional Development, the CPD certificate, there'll be a survey we'll put up near the end of the presentation, and you just put your information there, and we'll record this. So we'll send a copy to you if that's helpful, and also put it up on our YouTube page. Thanks. Next slide. A lot of you may have come across this already, but Virtual Specialist Consults is a specialist service across Victoria where patients and people in the community can join hospital clinics alongside their GPs, work together so that they don't have to physically come in a lot of the time, and care is kept in the community with you as the primary care providers, or with us, I should say. And that's going to keep people well and at home for longer. And also because they don't have to drive and we don't have the physical space needed, you can get seen a lot quicker, so within a week sometimes for certain clinics. And again, there's information on the website about ways we recommend accessing, and also those patient and support item number codes, which have come online now. Next slide, please. It's all on the website. Just because we started a bit late, I want to get over to Aveena. So next slide, please. Lots of specialties. If there's any that you think would be helpful, please feel free to email us, and we'll make sure we look into organising that. I think one more slide for me. Then I hand over. So Dr. Aveena Anantharajah is a respiratory and sleep paediatrician who leads the paediatric sleep service at Northern Health. She runs a hospital in the home-based oximetry service and also consults at VSC. And she also founded a private paediatric sleep service specialising in home sleep diagnostics for children called Prana Paediatric Sleep Service. So I'll hand over to Aveena, and thank you all for coming tonight.
Thanks, Morgan. Thank you for that really kind introduction. I'm just going to forewarn you that my two children have just walked in through the door, and I don't know the outcome of my oldest daughter's basketball game. And if they do come in, they might say hello, but we'll quickly get them out the door as well. So without further ado,
Is that all right?
I would love to outline what I'll be talking about today. So essentially, topics that are really valuable to think about as a primary care provider. You're the first responder in essentially all these issues. And I think one of the things that is really hard to manage is how it sometimes feels really nebulous. So I'm hoping to give you really a pragmatic, very practical solution to a few of these problems. So the four things specifically are the circadian rhythm disruption in adolescence, specifically issues around sleep in neurodivergence, so specifically ASD and ADHD as well, restless sleep and how to approach it. And I think a topic really close to my heart, sleep disordered breathing in obese children. the thing is, I'm really passionate about making sleep and breathing better for all children. And it's really quite a privilege to be able to work in the virtual specialist consult. And like Morgan talked about, it's really beautiful that there is the co-consult and case conference option as well, that really helps in building a strong relationship with primary care providers. But also knowing that at Northern Health, I run an in-person clinic both in Epping as well as Mernda, and I've got the capacity to see some of these kids if I see them in the virtual setting and they need to be seen in person. And that can sometimes be the case for the neurodivergent kids or the adolescents who are not engaging especially well in a virtual setting. I have the capacity to bring them in if they're within the northern catchment. I love showing this video to start off with because sleep is so deeply personal. It is different for every single person, and there are tiny little feet coming in. Sorry, I can't hang out after 7 p.m. My baby needs my ear to fall asleep. Clearly, this mum or this bub potentially has a sleep association disorder, but really, depending on familial context and cultural differences, it may not be a problem. For some people, it might be something that you want to help address if sleep is an issue and it precipitates in behavioral insomnia. But specifically, these are issues I'm not going to be exploring today, but I'd be more than happy to send you resources or information that might be useful. So I'm going to quickly dive in with a precursor slide and then illustrate through 6 cases the 4 topics that I'm hoping to kind of give you more of a practical lens to. So in adolescent sleep, it's highly variable, the number of hours, which is the sweet spot for each child. And a big part of it is dependent on what your genetic predisposition is. So if your parents are more likely to be long sleepers, you're more likely to feel rested with 10 hours per night or 24-hour block. But some kids only need 8. But by and large, the average sweet spot is somewhere between 9 and 9 and a quarter or 9 and a half for every 24-hour block. And I think the reality is with the increasing demands of society, school, extracurricular activities, especially in adolescence, is unbelievably difficult and hard. And then you throw in the advent of social media, screen time. It's unbelievably difficult to be an adolescent in 2026 for lots of very obvious reasons that we probably experience as adults. So essentially, up to 3/4 of kids report sleeping less than 8 hours per day, and that really demonstrates that insufficient nocturnal sleep is a primary issue that results in daytime sleepiness. Up to 15% of kids have delayed sleep phase disorder, and I suspect that that's a gross underestimate. A big part that happens in puberty is it delays your internal production of melatonin to occur later on in the night, and many teenagers have delayed sleep phase. And interestingly, when they've studied adolescent monkeys, they find exactly the same physiological phenomena. But unfortunately, there are some genetic phenotypes or essentially some phenotypes that present worse than others. And a big part of this is a biological drive to sleep later. This is not just poor behavior and a bedtime resistance. There is a biological drive to it. So let me just end this slide with saying that it's a skill to learn to sleep and it's a skill to learn to wake for school, especially when you've got delayed sleep phase. So you're more likely to fall asleep later and unfortunately also wake up later. Society is not built to accommodate for delayed sleep phase or normal adolescent physiology. And then it's also a skill to limit screen use in 2026. So I'm going to start with the first case, Eddie. And if the GP, Rebecca Lee, is around, I just wanted to do a big shout out to you. You were our first GP case conference talking about this exact child. So a 17-year-old boy, and actually you inspired me to do this talk. So thank you. It's a 17-year-old boy wanting to, he came into my rooms essentially saying, I want a sleeping tablet, doc. I need to sleep. I've tried everything. Nothing works. I've done melatonin, immediate release, Circadian, spelled incorrectly. Apologies. He's clearly got fluoxetine, but he's now gone off it because you know what? His mood is not that big a problem. But he's essentially said, no, it's not. It's not working. Nothing is working here. I'm going to sleep. And if you look, I'm going to orientate you to the sleep diary. And if you can see my cursor, these are the days, the date. It's starting at midnight. It's ending at 11 p.m. Each single square is an hour of an epoch of time. And the first line is just an example to demonstrate to the kids if it's colored in black, that means they're sleeping. If it's left empty, that means they're awake. To be honest, as a sleep physician, I find sleep diaries are incredibly helpful, just as good as a pathology result. And this kid comes in and says, yeah, I can't sleep. Sometimes I'm up till 4 in the morning, nothing works. And then I just wake up at 12. I don't know what's wrong with me. Fix me. He's seen an adult sleep physician, but nothing was working. They've essentially done a level 1, which is an in-lab sleep study. They didn't find any obstructive sleep apnea, but they did find some periodic limb movements and restless sleep. His iron was borderline low, but really 24, so technically normal, but he was super restless, and his periodic limbs were well above 15 to 20. He was started on gabapentin, but by the time I saw him, he was missing heaps of school. He had to switch to a different school to complete the year, to essentially make it and complete VCE this year. And really, his hopes were to be someone that could join the Air Force potentially next year. But I mean, my approach is reasonably simple, right? Like, I go back to the basics, I talk about what we can do and you will see illustrated in the subsequent cases why iron is important. But I said, keep going with the iron. You're clearly a restless sleeper. The reason why it's important is iron is a cofactor for the way dopamine is made. I got him to get some sleep diaries for me, and I said, hey, the single most effective thing in your sleep to change from today is you wake up at 8 a.m. So if you're going to bed at 4 a.m., I want you to wake up at 8 a.m. And I guess that's one of the most valuable things to talk about. It works for some, not for all. But again, by this point, I didn't have any sleep diaries, but I'll demonstrate to you what happened next. We talk about the why. So I explain to these adolescents what is process SNC, which I'm going to talk about in the next few slides. No screens for 60 minutes before bed. And then I saw him in person in 4 weeks' time following this appointment. He was starting to, enjoy going to the gym. And I said, dude, this is amazing. It's super protective for sleep. Keep going. And then the other really big thing for anxious teenagers in current society, I give them the permission to be good enough and not perfect. And I'll talk to you a little bit more about why that is. So this boy eventually comes back to see me, and I didn't prescribe him any new medications. I said, let's just talk. Let's see what's going on. Give me the data and let's assess. So he comes back in, and interestingly, over the school holidays, he ends up sleeping a grand total of between 8 to 9 hours. He didn't take his melatonin because he was at his dad's house, and he wasn't going to the gym in that time. The day school started, what do you see? He's struggling to fall asleep. He's waking up at 12, and this essentially repeats nonstop. He's trying to get back to a sense of normal with sleeping at 11, but really then it carries on this way. Essentially, this kid has a situational circadian rhythm disorder. It's exacerbated by stress of school. And I didn't do very much. I sat there and I just used motivational interviewing. And I asked him, why do you think that is? He came to the conclusion himself. Also, we got to the bottom of why he was struggling. One of the things that was happening was he was having this pre-gym workout drink that had about 250 milligrams of caffeine in it. And funnily enough, in about 4 weeks from the last time I saw him, his restless sleep had dramatically improved on the iron and the gabapentin. And just a plug for the pre-gym workout drinks or the kids drinking boba, iced teas, and all the caffeine that you can imagine. Caffeine is really, really an interesting thing. It competitively binds to the adenosine receptors and really stops you from building sleep pressure. So your body might continue to get fatigued along the day, but your brain gets tricked because you're blocking off the neurotransmitter pathway and you're unable to feel like you're tired. Again, it's more susceptible in some than all, but it's valuable to think about. I'm going to quickly go into case two, but then move into a bit of the background as to process CNS. So case two is another very similar case. It's a 17-year-old boy in year 11. He has ADHD. He's coming to me because his brain feels wired. He's unable to fall asleep. He's usually falling asleep at 2 in the morning. He's on stimulants for his ADHD. And really his main issue is I can't wake up. His parents describe him like this fiery dragon. And actually, he's it's resulted in about 40% school absences, which the school, which wasn't a very fancy pan school in Melbourne, essentially said, unless you change this, there is no way that you can continue on the current regime. Let's try and figure out a solution here that's going to work. I'm going to pause here and say to you that this is our bread and butter in pediatric sleep. But again, general pediatricians do a lot of sleep disturbances in neurodiversity as well. But I'm going to nut through with you the two-process model of sleep. So the concept is when light hits the eyeball here, and these might be concepts that you've already covered in medical school, but if it's anything like my experience, I got very little sleep education. And even then, it was a very long time ago. So I'm going to give you a bit of a refresher, a quick one. So when light hits the retina, it essentially stimulates the suprachiasmatic. I'm never going to be able to say that word, but the SCN, which is the master clock, and melatonin is then secreted from the pineal gland. Melatonin is released when the light levels fall, right? So it's an internal signal to light. This is process C, which is the circadian rhythm. So this is your degree of alertness. It obviously peaks sometime in the second half of the day. And as the day wanes and night comes, this is the biological night, your alertness is at its lowest. Now, it's this beautiful symbiotic relationship with process S that results in successful sleep. Process S is your sleep pressure. And essentially, it is driven by how much adenosine accumulates during the wakeful period. So as you wake up here, you're awake, adenosine is peaking, all right? When your head hits the pillow, boom, the pressure discharges and you're becoming less sleepy the more sleep you get. And then by the time you get to the end of your night period or your sleep period, your sleepiness is down here. And then again, off we go. So again, caffeine competitively binds to the receptor, the adenosine receptors. I think it binds to A1 more strongly than A2A, but the bottom line is caffeine looks very similar to adenosine. So essentially, it tricks your brain into thinking you're not sleepy, but your body might be wrecked. I'm going to give you a series of 4 different scenarios, okay? So, for example, if you've got a kid that comes in and they're having plenty of naps in the daytime, this example here is a nap between 3 to 4 p.m. So the sleep pressure is increasing. This is process S. What happens after a nap is your alertness or wakefulness improves, right? So the sleep pressure drops dramatically so that by the time you've woken up and you're trying to build your sleep pressure again, it's 11 p.m., you need to go to bedtime, your sleep pressure is nowhere where it should be. It's clearly not ideal. So what happens then as a result of this nap, you're going to fall asleep later on in the day, right? And then it's eventually going to have a kind of domino effect for the rest of the week. This in reverse is what happens if you go to bed earlier, much earlier than your sleep pressure is suitable for. So you've gone to bed here where ideally you should have gone to bed somewhere later on in the night. You struggle to fall asleep. If you're spending more than 30 minutes falling asleep, that's clearly not ideal. It leads to anticipatory anxiety. Why can't I sleep? There's something wrong with me. And then your mind goes, it's in this loop that you can't get out of. What do you do, right? So in the sleep physician world, we try very hard to shorten the time in bed, but get you to the sweet spot. And then we eventually try and get as much consolidated sleep. What happens if you go to bed later? So this kid has gone to bed at 1 a.m. Clearly, you get to bed later, you fall asleep straight away because your sleep pressure is super duper high. Unfortunately, the end product is if you need 9.5 hours of sleep to feel rested, you're going to wake up later, which means that you get a shorter amount of light exposure hitting your brain and then the signaling to the pineal gland. Unfortunately, the downstream impact is just that domino effect. So what happens if you sleep in? The consequence of this, essentially everything gets pushed back to later. Your pressure to sleep then gets pushed on to later and later and later. So now we come back to case 2. So this boy with ADHD, who unfortunately, in addition to taking stimulants, was also drinking bubble tea virtually every day, maybe a couple of times. That was his kryptonite. He just needed it. But this boy at times would wake up at 12 p.m. Sometimes he would just stay in bed, hard to wake out until about 4 p.m. There was marked sleep inertia. What did I do with him? Just go through the basics. Is it a problem of sleep volume? So you get that with the sleep diaries. Is it insufficient sleep? If there is insufficient sleep, it usually leads to stacking the REM sleep in the second half of the night. And that usually manifests as, the dragon waking up in the mornings and it's really, really hard. That essentially looks like sleep inertia. I would check that there is nothing interrupting sleep quality. So this boy did not have any symptoms of obstructive sleep apnea as listed there. But in regards to restless sleep, this is something that kids don't offer up. You tell them, hey, what's the problem with your sleep? They will never tell you the last few things on the slide. Ask them specifically, do you find it hard to get into comfortable position? Does your lower limbs or your legs feel funny before you go to sleep? Is there any funny repetitive movements that you feel like you need to do? Do you ever cycle your legs? This boy eventually came out and said, actually, I feel this vibrations in my legs. So much so that I can't sleep. I can just feel it vibrate, vibrate, vibrate. And sometimes it feels fizzy, but I can't explain it. And he's 17, he's eloquent, he's super intelligent. This boy has restless leg syndrome. And then the more you dig, and this is the end of a 45-minute consult, trying to get everything out for this kid, it was very, very clear to me that he had RLS. So the way I managed this was I optimized his iron. His iron would have been less than 20. And then I followed this boy up for several months. I usually manage their low iron stores for about 4 to 6 months. And I would say and hazard a guess that maybe about 90% of the time, oral supplementation is more than enough. I rarely ever need to, in this particular scenario, need to go to an iron infusion. Although the emerging data from North America would have a more trigger happy approach for an iron infusion, I seem to get away fairly adequately with oral supplementation if your patient takes it. I'm gonna switch tacks here and talk about my tree. And these are, by the way, made up names for real scenarios. Mayatri is a 12-year-old girl with autism spectrum level 2. She's really struggling with school. I'm going to give you an impression of a case that really caught me off guard and share with you why I find this to be such an incredible specialty. It's super interesting. But sometimes, even if I've done thousands of these consults, they sometimes just catch you off guard, and this was one of them. She presented with excessive daytime sleepiness. She came from a South Asian, very conservative family, very culturally diverse, and mum was non-English speaking. She was really difficult to rouse in the mornings. She slept very frequently in the daytime. As you can see, her sleep diary looked more like a checkerboard than a sleep diary. It was really confusing to me what in the world was going on. And she was having lots of school absences. Weirdly, the family started reporting this phenomena of cataplexy. And I don't know if any of you in the room know what this phenomena is, but it's really fascinating. And it's not something that people just lead with. They describe it to you and they're like, oh, I just have these sudden, falling episodes. It doesn't really make sense. You probe a little bit more. Cataplexy is a phenomena of, it can range from facial cataplexy, a gentle lull of the neck, gentle kind of falling of the upper body, all the way to buckling at the knees, all the way to a total collapse. It's sudden onset, usually secondary to something really funny that is spoken about by a friend, something really scary, watching a scary movie, or a really big burst in emotion. And then it's a very short-lived and self-resolving episode. It's very classic for narcolepsy type 1. So when this girl was reporting these symptoms, I just went, this is really odd. Does she actually have narcolepsy? But her symptoms don't fit. She had a comorbid diagnosis of depression. She was known to the mental health team at the Royal Children's Hospital, which is how she ended up coming to see me as a sleep physician. And she sent me down this really interesting path. So I do, on all of the kids that I see, 2 questionnaires at starting point. The ESS chat is the Epworth Sleepiness Score for children and adolescents. It's a bit old and archaic now because you can see it was finalized in 2015. There's probably a few questions you would like to change here, but this score is out of 3 in each question, and the whole questionnaire is out of 24. And you can see here that any score above 11 is very abnormal for sleep. She's got a score of, what is this, 12, 13, 14, 15, 16, 17 out of 24, which is clearly very abnormal. And then everyone gets an OSA 18 as well, which is a quality of life score specific to obstructive sleep apnea, but it does give you a few interesting things. Like, for example, this question here, it's a caregiver question. How likely are you to be worried that your child is not getting enough air in? And that gives you a demonstration of, is your child struggling to breathe? This is the way I perceive that question. And they've said yes, along with a lot of loud snoring. So the probability that this was going to be obstructive sleep apnea was high, but the history of cataplexy doesn't make sense. So she went on to have a sleep study. She had an overnight sleep study as well as a daytime test called an MSLT. I'm not going to go into that bit with you, but the more pertinent findings from the study. So I'm going to orientate you. This is called a hypnogram. Non-REM is yellow, green, dark green. This is the restorative stage of sleep, non-REM 3. REM sleep is in maroon here. When you see it like a big block like this, uninterrupted, that's good. That's exactly what we want to see. Once you start seeing it look like piano keys here, that's bad. That gives us an indication that there's significant fragmentation. And the question is why that is. This is body position, her oxygen levels. You can see that there's minor desaturations, but nothing profound. She's got normal gas exchange. And these lines here indicate that she's got significant obstructions to the tune of about 20 per hour. So just for context, that's like someone poking you awake every 3 minutes in your sleep from an obstructive event. There is no doubt in my mind that this girl has terrible, poor sleep as a result of severe obstructive sleep apnea. She's also got very mildly elevated periodic limbs, but I'm not particularly worried about that. This human set me on a bit of a goose chase because I went looking for narcolepsy and found severe obstructive sleep apnea. And then I realized that she had just found that she had started to love ChatGPT. And she started looking up what narcolepsy would present like. And then she would pretend like she had narcolepsy symptoms for me the first and second time that I met her. And then after this result, when actually, you know what, I don't have cataplexy. I never did have cataplexy. I just love ChatGPT. And I don't know if any of you in primary care have had any doozies as a result of the AI, I think, becoming such a big part of adolescents' lives. But this one really threw me a curveball. But it was I think a big learning curve as a young consultant. The fourth case is John. This is a really interesting one because it wasn't the stock standard. It was a 9-year-old boy, autism spectrum, level 2. He's waking multiple times a night. There is some history of snoring. So I went, maybe there's obstructive sleep apnea here. But when he wakes up at 4 in the morning, he just can't go back to sleep. And when you look at the sleep diary, he gets to bed at about 9 p.m. He'll wake at midnight sometimes and then stay up for 2.5 hours. Sometimes he'll wake up at 3 and then stay up all the way until the following day. It was really variable. There was no rhyme or reason as to why this was happening. It didn't make sense. But you can see this beautifully illustrated on a sleep diary. And when parents are willing to give you data, worth its weight in gold, because then you pair it with this result. So like we talked about, lots of fragmentation, not quite right, a very prolonged wakeful period, but it was a spontaneous waking because everything looked normal. Oxygen saturations, gas exchange, absolutely no event, no limb movements. This is a pristine looking sleep study beyond the fact that there is marked fragmentation and this prolonged waking. And then I went back to him and I went, what's going on here? Is it a sleep volume problem or is it a sleep quality problem? You're getting enough sleep when you do get it, and that's probably because you have multiple days of not enough, and then your body needs a couple of days to catch up, and then you go back to it. Usually it's a behavioral sleep issue, something that we haven't yet unpicked, like a sleep fear, a nightmare that's recurring, some sort of sleep phenomena that we don't really understand. But I know for certain, given the sleep study, I'm not worried about obstructive sleep apnea or restless sleep disorder. But this kid was very, very, very tired from not enough sleep. And the things that actually emerge in that sleep state is sleep paralysis and sleep hallucination. Let me walk you through what sleep paralysis is. I mean, I remember having one in my 20s and I thought that I was being like possessed. I mean, clearly we're all scientists in this room, right? But it's a really bloody odd feeling. So it's a phenomena moving from REM sleep to wakefulness. And in REM sleep, that's where we tend to do all of our dreaming. It's the kind of sleep stage where you're trying to decide, do I run away from the tiger? Do I pet the tiger? Do I give the tiger a hug? You're living out the different permutations of life, right? And you're learning from the mistakes. Sometimes your dreams go good, sometimes they don't go so good. Your body is paralyzed in this particular sleep state. And actually, what can sometimes happen is you wake up from REM sleep, you're awake, your body's still paralyzed, and you get this weird tingling sensation behind your neck. Sometimes you even see really big figures looking at you, and you get this feeling like a monster is licking the back of your neck. I don't know if you've ever felt that before, but if you have, it's scary. So, anyways, this poor little human, I realized, had started experiencing sleep paralysis. And I walked through it with him. I nutted it out. I normalized it. I said, hey, this can sometimes happen, but you know what? It's actually a normal thing. And it comes from, unfortunately, when you're not getting enough sleep. After we talked about it, I got this mum to do sleep diaries and then send it in to me. Look at what magic, like this magical thing that happens. Just the pure permission to realize that actually there was nothing wrong with him. He's okay. Allowed him to go to bed at 10. And this is with no medications whatsoever. He's sleeping between 8 to 10 p.m., waking up now between 6 and 9 a.m. The rare occasion that he is waking up here. There are some situations where there's early morning wakening at 5, but by and large, his sleep is largely better. And that's this really dramatic thing that can happen with sleep. There is the psychological component about sleep. This I think it takes time to sometimes unpick some of these things. And as I age in my specialty and grow more white hairs and learn as a parent and as a clinician, I realize that it's really the art form, right? As it is in general practice and a lot of primary care specialties, a lot of it comes with time. But I urge you with that particular case, just keep an open mind. If you think that it's not a sleep insufficiency or a sleep quality problem, think about, can we unpick the psychology behind it? And if it's something beyond your scope, have a think about who can do that for you. A sleep physician, there are sleep psychologists, they're few and far between. And in Melbourne, there are great sleep psychologists. One whose name is Frank Cahill. He works predominantly with adults, but is happy to see 12 and up. So if you need a sleep psychologist, I would recommend him. His company is called Sleep with Confidence. And there are a growing group of psychologists and GPs who have upskilled in sleep who would be very comfortable managing this, I'm sure. Case 5 is Eric. Eric is a 5-year-old boy. He lives on a cattle farm, single mom, escaping DV. It was really unusual. He had multiple night wakings. Mom was so worried about him. She kept going, is this trauma behavior? Is this trauma behavior? Because he'd been doing this since about the age of 2, body rolling back and forth, frequent night kicking, scratching his legs, saying ants were crawling all over him, help me, and actually crying out in sleep. He had marked daytime fatigue. He was melting down. He had a balanced diet, like, true blue farm kind of diet of lamb cutlets, eggs, chicken, and dal, because he was also part South Asian. And the mum just kept going, is this ADHD? Am I missing something here? Can we do something? He had a completely unobstructed airway and a normal cardiorespiratory exam. And this mum wins the medal for the most number of videos I have ever received from one family unit. 37, guys. 37 videos. And the reason for that is she had one of the cattle farm infrared videos that would motion detect. And as soon as there was motion, it would just automatically capture. And it was incredibly helpful. And I'm going to share this with you. And please, just because it obviously pictures this boy's face, even though it's a bit grainy, do not share this data openly with anyone. This family has very kindly shared it from an education purpose. But let me walk you through it first. So he's awake, he's kicking his legs, and he's clearly saying to his mum, Mummy, can you massage my legs? Just massage my legs now. And he does this non-stop multiple times a night. This boy had a ferritin of 1. I don't think I've ever seen a 1 before until him, with an anemia that was, not particularly profound, a hemoglobin of 107 with otherwise normal bloods. We started him on some supplements with marked improvement in restlessness. He's now sleeping through. He's not waking or calling out at night. He's waking up more refreshed. And initially I went, surely iron is not enough in this, right? Surely. I'm going to walk you through now what restless leg syndrome is and the difference with periodic limb movement disorder, but I like to think about this within the spectrum of the same umbrella. It's a neurological, primarily sensory disorder. It's this irresistible urge to move your legs. That's restless leg syndrome, with an uncomfortable sensation in your extremities. Periodic limbs is a bit different. I feel like sometimes people with restless leg syndromes have periodic limb movement disorder in a sleep study, but it's very much a thing where people, periodic limbs, I mean, some people don't give you the history for restless legs, even though you're purposefully probing. But when you do the sleep study, you detect the periodic limbs and it comes out like they're running a marathon in their sleep. And most is exacerbated by movement. RLS is a clinical diagnosis. You do not need a sleep study to diagnose it. Patients with RLS are aware, PLMD are not. Let me give you an example of a picture that I just grabbed from Up to Date, but actually a lot of my patients tell me things not dissimilar to this. I get all of my patients to draw on a little etch-a-sketcher, sort of like little pad. I don't know if I have one here to show you. And I get them to draw me pictures of what their sleep actually looks like. And this example is, my restless leg pain feels like the bones deep in my legs are being hit with a hammer. They only feel better if I move them constantly. It keeps me awake at night. So what I tend to do is 3 things. The conservative stuff is get them to do star jumps, as in like I prescribe exercise 2 hours before bedtime, short burst, trampoline, anything that you've got in your house that you can pragmatically get your limbs moving, a warm shower and a massage before you go to sleep. And then the real mainstay in a lot of this is fixing their low iron stores. And the underlying mechanism is iron as a cofactor, as I said before, for the way dopamine is synthesized in the body. And there's lots of hypothetical relationships with iron metabolism and where it might be the weak point, but the bottom line is iron is super important. In lots of case series, they found that 75% of people with significant RLS have a ferritin less than 50. So when we think about what aim of ferritin we're trying to get to, I'm really trying to achieve a ferritin of 75. I don't have a hard and fast rule about this. I don't always repeat it. If there is significant improvement in symptoms, I take a pragmatic approach. But if there is very little improvement, I tend to repeat it usually after about 4 to 6 months of supplementation, if it's working and just taking a bit longer to work. The other thing I'd like to also point out is usually you're going to have some dramatic improvement within the first 4 weeks. And if you're not having any significant improvement in after that first 4 weeks, and it's not that, go looking for something else. Could it be that this is not restless sleep disorder? Is there something else causing them to be restless? Send them to our clinic and we're more than happy to kind of go through it with a fine-tooth comb as well. Conversely, many children with iron deficiency do not have restless sleep, but I can tell you in my private world, there is so much periodic limb movement disorder and restless sleep disorder that's just partially treated or not even thought about. This is my last case, and how are we going for time? We've got 15 minutes more. Muhammad is a really, I think, poignant case that illustrates a few very critical parts of pediatric care, but specifically breathing and sleep related management. But it's a topic that I find very interesting, and it's a space that I love working in. Mohammed is an 11-year-old South Asian boy referred by his GP. He was seen in my in-person clinic. He had a very clear history for obstruction. He got an oximetry and then a sleep study at Monash. He was tired despite the 9 hours of nocturnal sleep. He was loudly snoring. But really, the bottom line for this kid is he walks in with his father. We know he's got severe OSA, but he's non-compliant with CPAP. He does not use it. Both the mum and dad were morbidly obese. The dad was obstructed awake, so he would sit there in the room tripoding, like constantly just obstructed breathing awake. And when I examined this poor little human, he had a BMI of 43, 120 kilos at age 11, with all the features of hyperinsulinism and a buffalo hump. He had a mildly obstructed looking airway, so grade 2 tonsils, but when you looked in his nostrils, it was unreal. He had near total obstruction of the left nair with total obstruction from nasal septal, a really severe nasal septal deviation, atraumatic. This is not Muhammad, but this is what Muhammad will be probably in about 4 years' time if we do not intervene. And I see so many kids at the Northern who unfortunately carry all the risk factors like this young man. Mohammed had abnormal LFTs. I'm not sure why it doesn't project very clearly there, but he had significant hyperinsulinism with an abnormal HbA1c of 6.1, with some abnormality on the liver ultrasound as well. Reassuringly, his echocardiogram was normal with no evidence of pulmonary hypertension. This is his oximetry, and I'm going to orientate you. This is the oxygen trace. This is the heart rate variability. His mean SpO2 is 94%, which is often what we find in obese children. It's positive for OSA in that there is a cluster here, there is a mild cluster here, and a cluster here. But he went on to have a full sleep study, hypnogram, very fragmented, slept on his back, which is good for detecting obstruction. This is the SpO2, and you can see that 100% is the baseline, or somewhere 90-ish, 95% is the baseline. And then where it starts to look like paint dripping here, 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 and here are severe clusters of desaturation with abnormalities in gas exchange at times. He didn't meet the criteria for hypoventilation, but he had significant obstructive hypopneas, so much so that he had abnormal sleep architecture with a reduction in his non-REM 3 as well as REM sleep, and essentially an obstructive index that was like someone poking him awake once every minute. So what next? He had urgent surgery at Monash Children's. I reviewed him 2 days post-op. He was doing really well. My main question is, does he need CPAP thereafter? Management of OSA is a great way in obesity. Manage the OSA, you improve the motivation to try and do extra things. Compliance to CPAP can be tricky in this cohort. The mainstay always is and always will be increase body movement. I try to get them to do what's recommended from the 8 Healthy Habits, which I'm going to show you. It's a New South Wales-based program. It's the 8 Healthy Habits for all children under the age of 18. And it's talking about, the normal things, how much water to drink, exercising for an hour a day in that age group, managing OSA in obesity without the broader stigma. And you can imagine, right? You go to an obesity clinic, there's this, okay, there's something wrong with me. I'm obese. This is what I'm here for. Whereas when I see them in my sleep clinic and do obesity management, it doesn't carry that same degree of, okay, I am the problem, which is, I find helpful. I refer them to the weight management clinic at the Royal Children's if they're eligible, and if they've got obstructive sleep apnea, they are. But it's a triaging service that then gets them back into the community. And this is something that's become a special interest of ours at Mernda Community Health. So the question is, this kid really needs a multidisciplinary team. He needs a dietitian, psychology, exercise physiologist. The question is, can we start him on some metformin? And in the era of GLP-1 agonists and GLP with GIPs or GIPs, I feel like this is a really exciting time to care about these things because it's changed the stigma approach, it's changed the options. There are medications that are available for obviously people above the age of 18, and you would be experts in the room listening here, so I'm preaching to the converted here. But the 12 to 18, there is much less on the ground use for it. I don't prescribe it, but I phone a friend, and there are plenty of friendly pediatric endocrinologists who are very willing to do it as long as the families can afford it. I mean, it's really nice to hear that it's come off patent, or the Ozempic has come off patent this year. So I'm hoping that in the not so distant future there will be much cheaper generics available in Australia. So I guess the impact of untreated obstructive sleep apnea in obese kids is significant. It presents with daytime dysfunction, and I hope I've demonstrated to you that that usually, unfortunately, results in number one, delayed attendance in school, marked school absences, sometimes bullying at school, a poor quality of life, marked impact on neurocognition with sleep fragmentation. And to be honest, the data would suggest that even the modest use of PAP, so even several hours, between 1 to 3 hours, can dramatically improve school performance and inattention. So it's really imperative to try and help. And I'm going to demonstrate to you an example of what I mean. And then the other thing that everyone worries about is the risk of sudden cardiac death. I think it's rare in children, but the really high BMI kids who are at serious risk of this, it's not unheard of, but it definitely does happen to a lesser degree than it does in adults. But that risk obviously dramatically increases in your third or second and third decade of life. So when I think about management of obesity, what is my mainstay? It's the, intense or moderately intense physical activity, talking about the 8 healthy habits. It's portion control, regular meals, snacks that are healthy, going through stuff. And I never thought as a sleep physician that this would be something I would be so passionate in. But turns out it is, and I do a lot of it with my general pediatric fellows that I supervise at our Mernda clinics. And sometimes we prescribe them metformin, and then, like I said, phone a friend for injectables should they be eligible for them. And I've grayed out the role for bariatric surgery just because it's so underinformed, underrepresented, and probably about 1% of all the bariatric surgeries that are performed in Australia are in children. But there are groups and really adult bariatric surgeons that would be experts in managing this even in children. But I'm not an expert in that space, and I would let them speak for that. So really, the management kind of pathway is first line, always adenotonsillectomy to be considered, because if there is anything to evacuate and create space in the airway, that's the first thing we do. More than 50% is likely to continue to have significant OSA. What other treatments do we need? And that's probably positive airway pressure or CPAP, and that's the standard of care. It can reduce the cardiovascular implications, so specifically high blood pressure, and drop the blood pressure dramatically in a meaningful way. Um, but I think I'm going to pivot now to the pragmatic things that you can take home from here. What are the 2 questionnaires that I use often? And this is for any child with obstructive sleep apnea. The OSA 5 is succinct. It's the shortened version of the OSA 18 and then the OSA 11. The questions are pretty solid: snoring, pauses, choking or gasping, mouth breathing. But by and large, this is the one that packs the greatest punch. Are you worried they're not getting enough air in? And then they rate it on a Likert scale 0 to 3, and it's out of 15. The ESS CHAD, remember, it's the 8 questions, simple, again, Likert scale 0 to 3. These are examples of sleep studies, or what we call polysomnograms. There are multiple different types of sleep studies. The 2 that we often use in children are in hospital sleep studies, or in lab, in lab, which is in hospital, or at home sleep studies, which are newer and are things that we do very well in Victoria now. And then the last thing is a level 5 sleep test called the oximetry test, which I've highlighted here. So a sleep study or a polysomnogram is usually all of these things. These 2 at the bottom here in gray are in lab. This is what we would do in a home-based test. And in oximetry alone, you just get 1 parameter. But I'm going to demonstrate to you how incredibly powerful it can be for some kids. And just a plug as well, There is a new Medicare rebate item that's available from July this year, and children between the ages of 3 to 18 years will now be eligible for a Medicare rebate for home-based sleep testing. So it's a really exciting time to be doing home sleep diagnostics. Take home messages before we wrap up for questions. If they're sleepy in the day, consider doing the questionnaires, which I've demonstrated to you. Keep in mind we have access to a sleep diagnostics if we need oximetry or sleep study. Before starting any medications, get a sleep diary. If you're lucky enough to get a family member who can fill it in for you, it gives you a dramatic amount of information about sleep volumes. Explore the things that are not the obvious OSA, restless sleep disorder, periodic limb movements. Is there something in the sleep psychology that needs to be mitigated? If you're thinking about using melatonin, remember that there are big differences between, and I feel like I'm, teaching you how to suck eggs, so I apologize if this is the way it comes across. But the reason I say it is I often send kids with a script for immediate release melatonin, but then they come back to me 2 weeks later, or they give me a phone call and they say, hey, do you know what? It's not working. I don't know what you've prescribed. But the pharmacist actually changed it to this pill. They said it would be cheaper. And they've given them Circadian, which is a modified release preparation tablet. And it's clearly inefficient if the problem you're trying to fix, as you can all imagine, is sleep onset insomnia versus a sleep maintenance problem. Again, access is an issue. Voquili is the one that is readily available off the shelves that does not require compounding pharmacy. Circadin is the long-acting tablet form, small, tolerated, if you can swallow. If you've got a neurodivergent kid and we need to start something that is slow release because they have a problem stitching together their sleep cycles, then sometimes using something like a really small tablet called Slanito is helpful, but I usually get them in a pediatric clinic and then start that from there and then continue it with their GP. And if you've got any obese kids, the way in to manage obesity is actually through sleep, and it's a multi-systemic, but also probably a transgenerational solution that you probably get to do. If you need any resources or the questionnaires I've talked about, all of these resources are available on my private sleep website, pranasleep.com.au, or if you need, we also own the domain name charlesleep.com.au, if that's easier to remember. But there is a resources tab with all of this in there. And I'm just going to end with two last slides. This is an example of a 6-year-old girl who was morbidly obese, Samoan girl. And this was her oximetry that we did at the Northern Hospital. She was snoring. The parents were like, something is not right, but I can't really put my finger on it. I actually have to kind of hold her mouth in a particular position and roll her or poke her awake multiple times a night. So let me orientate you. Her mean SpO2 is 84%. I've never seen an oximetry go down to the single digits. And these are marked really severe clusters of desaturation. And when you look at the parameters, she spent more than 50% of this entire night below 90%, which is diabolical. She obviously got, as you can imagine, and this is where oximetry alone can pack a punch. You don't need to progress to a full sleep study. We can act on this. So we got her in within a week. She had an adenotonsillectomy urgently at the Royal Children's Hospital. She was initiated on CPAP during the same admission. She went home, and this is her oximetry now. Unbelievable. When I saw her, she was bright, bubbly, engaging. She was unrecognizable. And then she gave me a hug. And I just, yeah, it's amazing. What I do is amazing. And if you've got any questions, please feel free to give me a buzz or reach out. But that's the end of the discussion or the presentation. So feel free to please ask the questions.
Yeah, thank you, everyone. Please put some questions in the chat if you'd like, but we'd also feel free to unmute and ask away. Where it's close to 8, so maybe only do 1 or 2, and we can follow up any others if you want to send us an email. I'll hand over to the floor if there's any particular questions to start us off.
I promise I don't bite. Feel free.
Okay.
Or if you've got any tricky cases that you want to maybe even mention to me or ask me, or if you've had any, Karina.
Yeah, I'm just wondering your thoughts on use of clotidine for children with ADHD.
I love it. Clonidine is really helpful. You have to pick the right kid to use it in, I find. So they've done lots of studies in North America that have shown that the kids who get diagnosed with periodic limb movements have a comorbid diagnosis of ADHD in 90% of the time. And clonidine is usually my second line medication of choice. In trying to treat periodic limb movements. It's a bit of a roundabout way to answer your question. I love the medication. It's an alpha agonist. It's great in sedating to try and fix sleep onset insomnia, but it's got the two-pronged effect of also targeting periodic limbs. But in the kids who have ADHD, I would make sure that you've optimized their iron, and you've made sure that there's no nutritional deficiencies. And if we need an option, I would start with clonidine. Sure, especially if they've got restless sleep, but I wouldn't always have every single kid with ADHD on clonidine. There is a role to consider melatonin if you're trying to treat sleep onset insomnia that's come as a result of starting stimulants, which, as you can imagine, is a really common side effect of starting stimulants and the commonest reason to like reach for a sleep aid. Does that answer your question, Corinna?
Yeah, and just a follow-up is are there concerns about the use of melatonin and its impact on puberty? Because I've sometimes read that there are some issues with that.
I think it's really hard. So I guess the question is in what age group and around puberty being, are you talking about the peripubertal stage, the prepubertal stage? Because I'm going to be honest, or finish, maybe answer that first and then I'll continue.
Yeah, so children who are approaching that period of puberty, so like maybe say 8 to 12.
Yeah. And I think it's really hard. It doesn't stop me from using it because I think poor sleep precludes like optimal daytime functioning. So the thing I would say is start low, go slow, like everything in medicine. I think the danger with melatonin is misuse, overuse, too high doses. And as a sleep physician, I sometimes even use zero point 0.5 milligrams. I have patients who are so susceptible to melatonin, I use zero point 0.1 milligrams. Um, there was a study, a small study in neurodivergent children that showed a really beneficial use of melatonin as a chronobiotic. So I think melatonin is actually a really beautiful drug when used wisely. And if it's a circadian rhythm problem and you're trying to reset the circadian clock, sometimes I do a microdose, so like zero point 0.2 to zero point 0.3 milligrams of immediate release melatonin 4 to 6 hours before the intended bedtime. And then sometimes I follow it up with a sedating dose of melatonin, and that's usually 1 to 1.5 milligrams of melatonin about 30 minutes before bedtime. I rarely ever need to go up above 3, 4, 5 milligrams. I would say that those patients are few and far between, but I have had some patients who've been on 10, 12 milligrams, and you're more likely to get the complications with much higher doses. Tyra.
Yeah, over to you, Tyra, and then we might wrap up there. And any other questions, feel free to email it through.
Would you like to come off mute, Tyra?
That's all right. We'll go.
I think there
Joanna, do
was.
you want to? Oh, if I'm not sure what's going on, Tyra, but Joanna, did you want to quickly ask, and then Tyra, maybe you can either send us an email or do a co-consult if it's about a particular patient. That's all right. Look, might be a bit of tech issues going on. Either way, thank you, Aveena, so much for your time. It's it's an area where it's a lot going on, and as mentioned, it's very important for patients and everyone to feel heard. It's very tricky to talk about it, and then know how to approach it in quite a kind of methodical way with the evidence behind you. And so I know definitely it would be, you can see those patients in your mind already where maybe a co-consult or a case conference might be really helpful just to all work on something together, and make sure that everyone's on the same page of where the best kind of steps could be with moving sleep towards something that's working for the family. So please go on to the VSC website and have a look and see if any of that would be of help to you and the people you work with and the patients you see. And we'll see you at the next webinar in about a month. I'll send out the information. And thank you all for your time. And thank you again, Aveena.
Thanks, Morgan, for moderating so beautifully.